Depression, what is it and why does it matter? Alright, I don't know a lot about depression. Like, I have it, obviously. I'm just staring at a Wikipedia page about it, and I just want to just read it to you guys. I think that's the best way to kind of learn, is to just listen to me read. So, major depressive disorder, MDD, also known simply as depression, is a mental disorder characterized by at least 2 weeks of low mood that is present across most situations. It is often accompanied by low self-esteem, loss of interest in normally enjoyable activities, low energy, and pain without a clear cause. People may also occasionally have false beliefs or see or hear things that others cannot. Some people have periods of depression separated by years in which they are normal, while others nearly always have symptoms present. Major depressive disorders can negatively affect a person's personal life, work life, or education, as well as sleeping, eating habits, and general health. Between 2 to 8% of adults with major depression die by suicide, and about 50% of people who die by suicide had depression or another mood disorder. The cause is believed to be a combination of genetic, environmental, and psychological factors. Risk factors include a family history of the condition, major life changes, certain medications, chronic health problems, and substance abuse. About 40% of the risk appears to be related to genetics. The diagnosis of major depressive disorder is based on the person's reported experiences and a mental status examination. There is no laboratory test for major depression. Testing, however, may be done to rule out physical conditions that can cause similar symptoms. Major depression is more severe and lasts longer than sadness, which is a normal part of life. The United States Preventative Services Task Force recommends screening for depression among those over the age of 12, while a prior Cochrane review found that the routine use of screening questionnaires has little effect on non-detection or treatment. Typically, people are treated with counseling and antidepressant medication. Medication appears to be effective, but the effect may only be significant in the most severely depressed. It is unclear whether medications affect the risk of suicide. Types of counseling used include cognitive behavioral therapy and interpersonal therapy. If other measures are not effective, electroconvulsive therapy may be considered. Hospitalization may be necessary in a case where the risk of harm to self and may occasionally occur against a person's wishes. Major depressive disorder affected approximately 260 million people, 3% of the world's population in 2015. The percentage of people who are affected at one point in their life varies from 7% in Japan to 21% in France. Lifetime rates are higher in the developed world, 15% compared to the developing world, 11%. It caused the second most years lived with disability after lower back pain. The most common time of onset is in a person's 20s and 30s. Females are affected about twice as often as males. The American Psychiatric Association added major depressive disorder to the Diagnostic and Statistical Manual of Mental Disorders in 1980. It was a split of the previous depressive neurosis in the DSM-2, which also encompassed the conditions now known as dysthymia, an adjustment disorder with depressed mood. These currently or previously affected may be stigmatized. So that's just a good intro. Let's go into the symptoms, because I know symptoms are like what everyone wants to know to kind of like self-diagnose. I don't recommend self-diagnosing at all. This is just for people who just want to know the difference between depression and sadness. Major depression significantly affects a person's family and personal relationships, work or school life, sleeping and eating habits, and general health. Its impact on functioning and well-being has been compared to that of other chronic medical conditions such as diabetes. A person having a major depressive episode usually exhibits a very low mood which pervades all aspects of life and an inability to experience pleasure in activities that were formerly enjoyed. Depressed people may be preoccupied with or ruminate over thoughts and feelings of worthlessness, inappropriate guilt or regret, helplessness, hopelessness, and self-hatred. In severe cases, depressed people may have symptoms of psychosis. These symptoms include delusions or, less commonly, hallucinations, usually unpleasant. Other symptoms of depression include poor concentration and memory, especially in those with melancholic or psychotic features, withdrawal from social situations and activities, reduced sex drive, irritability, and thoughts of death or suicide. Insomnia is common among the depressed. In the typical pattern, a person wakes very early and cannot get back to sleep. Hypersomnia or oversleeping can also happen. Some antidepressants may also cause insomnia due to their stimulating effect. A depressed person may report multiple physical symptoms such as fatigue, headaches, or digestive problems. Physical complaints are the most common presenting problem in developing countries according to the World Health Organization's criteria for depression. Appetite often decreases with resulting weight loss, although increased appetite and weight gain occasionally occur. Family and friends may notice that the person's behavior is either agitated or lethargic. Older depressed people may have cognitive symptoms of recent onset, such as forgetfulness and a more noticeable slowing of movements. Depression often coexists with physical disorders common among the elderly, such as stroke, other cardiovascular diseases, Parkinson's disease, and chronic obstructive pulmonary disease. Depressed children may often display an irritable mood rather than a depressed one and show varying symptoms depending on age and situation. Most lose interest in school and show a decline in academic performance. They may be described as clingy, demanding, independent, or insecure. Diagnosis may be delayed or missed when symptoms are interpreted as normal moodiness. Okay, so now there's associated conditions, other health problems. A lot of this, I hope is new to everyone. So just, I think one of the main stigmas of depression is that, there's no laboratory test to take it. It's basically purely based on questionnaires and certain models of testing that we give to people who say they're depressed. We give them these tests and we ask them these certain questions. Remember, I was given a test once. It was like, on a scale of, it was something like, my sleeping is good. And then you would write either strongly agree, somewhat agree, strongly disagree, or somewhat disagree, something like that. And they would kind of trace your symptoms of depression and say how depressed you are, So if you've ever been given a test by a psychiatrist and you don't really believe it, I mean, these tests are there. They're standard model tests. They're not laboratory tests, okay? They are, though, questionnaires that fit the bill for someone who has depression. Okay, and that's kind of why there's like a stigma. Like, who are you to question me about my symptoms? And what do you mean you can't tell me, there's no laboratory test for, there's no blood test for depression. Does that even make it real? These are things we just need to get over, man. Like, this is how we diagnose this. How else would we diagnose it? I mean, we diagnose it, right? There's no other way, unfortunately. It's simply through people telling other people, I feel, just really, really, I went to the symptoms, right? Those symptoms, basically. Irritability, lack of interest in things once thought interesting, lack of insomnia or hypersomnia, things of that nature. Alright, guys, at age 18, please stop watching. So, something I didn't know was you could hallucinate on depression. Like, I knew before of things called psychotic depression. I didn't know how common that was. I think what is more known as science has moved on, because I've been dealing with depression for 15 years, I guess. 12 years, I guess. I've learned at the beginning, I thought depression was just sadness, irritability in mood, fatigue, loss in contrast, loss in, concentration and difficulty sleeping. There's also another symptom, which is you can have delusions and hallucinations. You see things that other people don't see, and you have delusions of, for example, like your powers or chosen by God. These kind of things can definitely happen with people with depression. It's quite common. 1 second, guys. Go over here. Get my glove on. So this is for people who think, depression's not real. And it is real, guys. This is all based on science. Like, this is Wikipedia, and it's all footnoted. If you guys don't believe me, you can just go on the Wikipedia website and look at the footnotes. I'm not making any of this up. So there's different subtypes of depression. Obviously, there's melancholic, which is let's just go through them. There's 6 subtypes of major depressive disorder. First one is called melancholic depression. Is characterized by loss of pleasure in most or all of activities, a failure of reactivity to pleasurable stimuli, a quality of depressed mood more pronounced than of grief or loss, a worsening of symptoms in the morning hours, early morning waking, psychomotor retardation, excessive weight loss, not to be confused with anorexia nervosa, or excessive guilt. Please don't laugh when I said retardation. That's part of this whole stigma I'm trying to destroy. It's not funny. I don't know what psychomotor retardation is. I think it means like you have trouble like with fine motor skills. We definitely need to come up with better ways of coming up with better, like, names. Because we shouldn't use the word retardation anymore. It's just rude. Like, we use the word disabled or something like that. So then there's atypical depression, which is characterized by mood reactivity, paradoxical and hadenia, which is like you find pleasure in things that aren't necessarily used to find pleasure in before. And positivity, significant weight gain or increased appetite, comfort eating, excessive sleep or sleepiness, hypersomnia, a sensation of heaviness in limbs known as leaden paralysis, and significant social impairment as a consequence of hypersensitivity to perceived interpersonal rejection. I think that's what I had, atypical depression. Then there's catatonic depression, is a rare, and like I haven't been diagnosed with it because I didn't know there are subtypes. I'm learning this right now with you guys. So there's catatonic depression, is a rare and severe form of major depression involving disturbances of motor behavior and other symptoms. Here the person is mute and almost stuporous, neither remains immobile or exhibits purposelessness or even bizarre movements. Catatonic symptoms also occur in schizophrenia or in manic episodes, or may be caused by neuroleptic malignant syndrome, which is kind of like a rare kind of side effect of medications that you take for depression that kind of mimic the symptoms of depression. You got to be careful with that. You got to talk with your doctors about that. Depression with anxious stress. Distress is like the third one here, the fourth one here, which is with added in the DSM-5 as a means to emphasize the common co-occurrence between depression or mania and anxiety, as well as the risk of suicide of depressed individuals with anxiety. Specifying in such a way can also help with the prognosis of those diagnosed with a depressive or bipolar disorder. Then there's depression with peripartum onset, refers to the intense, sustained, and sometimes disabling depression experienced by a woman after giving birth or while a woman is pregnant. DSM-4 uses the classification postpartum depression, but this was changed in order to not to exclude cases of depressed women during pregnancy. Depression without peripartum onset has an incident rate of 10 to 15% among new mothers. The DSM-5 mandates that in order to qualify as depression with peripartum onset occurs during pregnancy within 1 month of delivery. It has been said that postpartum depression can last as long as 2 years. And the last one, which I am familiar with, seasonal affective disorder, which is basically a form of depression in which depressive episodes that come on in the winter or summer. In the autumn or winter, and resolve in spring. The diagnosis is made if at least 2 episodes have occurred in colder months with none at other time over a period longer. I don't know if I have this. I definitely feel this from time to time. I highly recommend, if you do have SAD or seasonal affective disorder, to get those UV lights that mimic sunlight. They're on Amazon, Walmart. I know Lights of America makes some really good lamps. They really help. They really, really help. If you don't have windows, you don't have natural sunlight coming in, those are a good substitute. Not a replacement, substitute. Alright. Now, obviously, the differential diagnoses. People think, oh, you diagnosed you wrong. So, I'm just reading here. There are other differential diagnoses. For example, bipolar or chronic fatigue syndrome, or, you could medications you're taking, or substance abuse. So that's basically why people would use laboratory findings to disprove, like, for example, you don't have a substance abuse or a medication you were taking, or chronic fatigue syndrome or something like that. Yeah, it's actually, that's what laboratory tests are used to rule out, right, these different diagnoses. Okay, so then there's prevention. So this, I think, is kind of important for people who aren't depressed yet. For people who don't want to get depressed, I'll just read this. And I don't recommend getting depressed. No one wants to get depressed. It's not a choice. As I said, it's genetic. So no one really has a choice in their genetics. Preventive efforts may result in decrease in rates of the condition of between 22 and 30%. Eating large amount of fish may also reduce the risk. Behavioral interventions such as interpersonal therapy and cognitive behavioral therapy are effective in preventing new onset depression. Because such interventions appear to be most effective when delivered to individuals or small groups, it has been suggested they may be able to reach their largest target audience most effectively through the internet. As I've been saying, the internet is such a huge tool for people who have anxiety. Because you don't want to leave the house, and you're stuck on YouTube, or you're stuck in your head, or you're stuck in that same old, let's face it, that same old routine of, nothing. I don't want to say the words, or just, you just do nothing. Rather than doing that, go on the internet and learn about depression, right? However, an earlier meta-analysis found preventative programs with a competence enhancing component to be superior to behavior oriented programs overall, and found behavioral programs to be particularly unhelpful for older people for whom social support programs were uniquely beneficial. In addition, the programs that best prevented depression comprised more than 8 sessions, each lasting between 60 and 90 minutes, were provided by a combination of lay and professional workers, had a high-quality research design, reported attrition rates, and had a well-defined intervention. The Netherlands mental health care system provides preventative interventions such as the Coping with Depression course for people with sub-threshold depression, or in other words, saying subclinical depression. The course is claimed to be the most successful of psychoeducational interventions for the treatment and prevention of depression, both for its adaptability to various populations and its results, with a risk reduction of 38% in major depression and an efficiency as a treatment comparing favorably to other psychotherapies. There's management, basically. Now they're going to talk about what is considered clinical depression. Clinical depression is basically people who have a history of moderate or severe depression, or those that have mild depression that has been present for a long period, or for those that have mild depression that persists after other interventions, or for those who have moderate or severe depression. Wait, I'm sorry, I read that wrong. Ignore that part. We'll just let's just talk about it real quick. Management of depression. The 3 most common treatments for depression are psychotherapy, medication, and electroconvulsive therapy. Psychotherapy is a treatment of choice over medication for people under 18. The UK National Institute for Health and Care Excellence 2004 guidelines indicate that antidepressants should not be used for the initial treatment of mild depression because the risk-benefit ratio is poor. The guidelines recommended that antidepressant treatment in combination with psychosocial interventions should be considered for people I just mentioned. People with a history of moderate or severe depression, those with mild depression that has been present for a long period, as a second-line treatment for mild depression that persists after other interventions, and as a first-line treatment for moderate or severe depression. The guidelines further note that antidepressant treatment should be continued for at least 6 months to reduce the risk of relapse, and SSRIs are better tolerated than tricyclic antidepressants. Then there's lifestyle changes. Definitely, physical exercise is a huge thing I recommended. Some say it says here, I've said this, my psychiatrist has said this, it says right here, according to Wikipedia, physical exercise is equivalent to the use of medications or psychological therapies in most people. Let's look at the footnote here. This is based on the Cochrane Database of Systematic Reviews, published by, I guess, Cooney, GM, Dwa, K, Greg K, Laura, TA, RMJ, Wog, a bunch of doctors, okay? So this is not like I'm making this up. If you have depression, going for a jog or just a walk around the block can help. This is not, something I'm making up or thinking like, oh, you just need to go get some fresh air. No, if you have depression, go for a jog. It really helps. All right, what else we got here? Other people say that there's other things too. Exercise, yeah. Other people say there's a small amount of evidence that skipping a night's sleep may improve depressive symptoms, with the effect usually showing up within a day. This effect is usually temporary. Besides sleepiness, this method can cause a side effect of mania or hypomania. They're saying quitting smoking has shown to be a benefit to people with depression, as large or as larger than those medications. Wow, I didn't know that. I quit smoking and I didn't know it was that big of a deal. Yeah, let's look at the footnote on that one, because really? Yeah, this is according to a journal. Okay. Let's see, cognitive behavioral therapy, variant, psychoanalysis, antidepressants. Oh, a big article here. Other medications, electromagnetic, transcranial magnetic stimulation, bright light therapy. Yeah, talk about this. Bright light therapy for seasonal affective disorder. We can go into the prognosis tomorrow and the epidemiology and history and all that. Society, culture, stigma. Let's end with stigma real quick, because that's kind of the whole point of these videos, to end the stigma. So let's I'm just gonna smoke a joint and I'm gonna read the stigma paragraph and I'll just end it. I mean, that's the whole point of these videos, is to erase the stigma around mental illness. You guys know I'm not a victim, like in terms of like, I don't want to play the victim in life or on these videos. I don't like being a pity party, so I don't believe in the over-diagnosis of anxiety and depression. I do believe, though, excuse me, in having a diagnosis of depression and anxiety. We can't just lump in all schizophrenics and all, serial killers with depressed and anxious people and say walk it off and stuff like that. It's just, a lot of people get through the crack. They fall through the cracks because of that, and it's, it's not there. All right. Historical figures are often reluctant to discuss or seek treatment for depression due to social stigma about the condition or due to ignorance of diagnosis or treatments. Excuse me. Nevertheless, analysis or interpretation of letters, journals, artwork, writings, or statements of family and friends of some historical personalities have led you to the presumption that they may have had some form of depression. People who may have had depression include English author Mary Shelley. I also heard Emily Dickinson as well. American-British writer Henry James and American President Abraham Lincoln. Some well-known contemporary people with possible depression include Canadian songwriter Leonard Cohen and American playwright and novelist Tennessee Williams, who wrote A Streetcar Named Desire, which I haven't seen. Definitely want to. Some pioneering psychologists, such as Americans William James and John B. Watson, dealt with their own depression. There's been a continuing discussion of whether neurological disorders and mood disorders may be linked to creativity, discussion that goes back to Aristotelian times. Interesting. British literature gives many examples of reflections on depression. English philosopher John Stuart Mill experienced a several-month-long period of what he called a dull state of nerves, when one is unsusceptible to enjoyment or pleasurable excitement. One of those moods when one is pleasurable, when what is pleasurable at other times becomes insipid or indifferent. He's obviously talking about anhedonia. Anhedonia. He quoted English poet Samuel Taylor Coleridge's dejection as a perfect description of his case. A grief without a pang, void, dark and drear, a drowsy, stifled, unimpassioned grief, which finds no natural outlet or relief in word or sigh or tear. English writer Samuel Johnson used the term the black dog in the 1780s to describe his own depression. And it was subsequently popularized by depression sufferer former British Prime Minister Sir Winston Churchill. Social stigma of major depression is widespread, and contact with mental health services reduces this only slightly. Public opinions on treatment differ markedly to those of health professionals. Isn't that weird? If, for example, I was reading a cancer article and it said, public opinions on treatment differ markedly to those of health professionals. I was reading an article about first aid for, a cut to the leg. Public opinions on treatment differ markedly to those of health professionals. Or if I was to, be reading a health article about drug overdoses, public opinions on treatment differ markedly to those of health professionals. Just to highlight the point and belabor it once more, if I was to be reading a Wikipedia article on, I don't know, nosebleeds, and I read public opinions on treatment differ markedly to those of health professionals. I mean, I'd be like, am I dreaming? I mean, is this like the world we're living in? I mean, you know what I mean? Because the stigma is unimaginable sometimes. If you have a bloody nose, you should be able to know what to do. You shouldn't be like, oh, this is what my doctor told me. This is what, I just walk it off and I just pray real hard or I don't know, just kind of believe that if I think about it more, I'm actually more sick than I am, and it's just a bloody nose. I mean, eventually it's gonna just, right? Eventually it's gonna just stop or something, right? If I just, I guess, right? As long as it's not broken, it's okay, right? And I mean, a bloody nose. Actually, that's a bad example. What I'm trying to say is, if I was to read an article about, for example, how, I don't know. See, that's the world we live in now. Science is under assault. If I have to, I'm trying to think of a good example. I just can't think of one because science is under assault. Like, to a certain extent, I kind of believe that statement, science is under assault, because look at this. Depression, people are saying public opinion on treatment is differ markedly to those of health professionals. For example, let's talk about something that people, want to know information about treatment for, like, let's say, I got a good one. Let's say your kid drank, Windex. So you obviously know what to do, right? You call the Poison Control Center and you go on their website and everything, right? And if they say certain things like, if your child is 6 and under and he has drank Windex, take him to the emergency room. If he has 6 and over, give him a medication or induce vomiting, right? You wouldn't be like, that doesn't sound right, because I remember in a movie one time, this guy, he drank Windex and, it was bad. He didn't take medication, he was fine. Right? You wouldn't think this is your child's life on the line. And instead you think, no, it's fine. Because we don't take mental illness as seriously as we need to. Unfortunately. We need to. And this just pisses me off right here. So, as I said, public opinions on treatment differ markedly to those of health professionals. Alternative treatments are held to be more helpful than pharmacological ones, which are viewed poorly. In the UK, the Royal College of Psychiatrists and the Royal College of General Practitioners conducted a joint 5-year Defeat Depression campaign to educate and reduce stigma from 1992 to 1996. And a Morai study conducted afterwards showed a small positive change in public attitudes to depression and treatment. That's the thing, man. Like in the UK, you have a lot of, I know as Muslims, in the UK you have a lot of Muslims. And they ascribe depression to the jinns. There's a lot of ruqyah performed, a lot of Quran recitation and stuff like that. They pray, and so people don't take it seriously. They don't really believe in it, and that's the sad part about it, because you're not educated, and if you're not educated, you're gonna make mistakes. If you don't know what's wrong with you, you're gonna end up more sicker. I've said this before, I'll say it again. I don't say I don't believe in devils and jinns. What I'm saying is, why do we always rush to the devils for depression, right? When it could easily be the other thing. Why do we prefer that over the other? You know why? Because it's easier. It's easier to prefer a devil or a scapegoat, the Jew, right? The black, the gay, right? The different. It's easier to blame the carpetbagger, any words you want to use. Even for history, the woman, right? It's ridiculous, and we blame our problems on these groups of people. In this case, these, spirit spirits, you know, and we don't see our own failings and our own faults. Yeah. So this wasn't gonna be a happy video. Sorry, started the new year off on a sad year. I wanted to get through depression though, in terms of like really cover it, because it's something I've been dealing with, something I've had, and you know, I struggle with it from time to time. It's, you know, I'm not ashamed to admit it. I mean, considering the things I've done, shame is very relative now. At this point, it's like, yeah, I don't even know if I can get any worse in terms of certain life choices I've made in the past. So might as well just keep going or take a risk. I think it really is like that. Okay, so just gonna end the video here, I guess, or I'm not sure. Let's just have some uncomfortable sounds for a while. Nothing I wanted to hear, I guess. Hey guys. Remember guys, I think I went from like a 5 to like a 0 or something. I wrote it down somewhere. It was like a 0 to a 5 or a 5 to a 0. It wasn't very high. Anyway guys, remember guys, stay with it. And yeah, stay with it.